Hello, everyone. Welcome to SD Life Endoscopy. And first, I'd like to thank Pharco Pharmaceutical Company for sponsoring our event. My talk is about management of acute upper GIT bleeding. Upper GIT bleeding is the bleeding which arises from esophagus, stomach, or proximal duodenum. The patients with upper GIT bleeding may present with hematemesis, melena, bleeding per rectum in cases of brisk upper GIT bleeding, and if the patient have previous upper GIT bleeding, may present with shock. The causes, there are many causes for upper GIT bleeding. The most common causes are peptic ulcer disease, gastritis, duodenitis, esophagitis, gastric and esophageal varices, malignancy, Maillard-Weiss syndrome, angiodysplasia, other causes, and many other causes, but these are the most common causes. The risk factor for developing a peptic ulcer disease or peptic ulcer disease or esophagitis or duodenitis or gastritis or non-steroidal anti-inflammatory drug, alcohol, radiation exposure, H. pylori infection. The first step in management of upper GIT bleeding is accurate history taking and examination and physical examination. History taking should include should include using of drugs like aspirin and steroids and corticosteroids, radiation exposure, history of chronic liver disease, history of chronic renal disease, family history of upper GIT bleeding, other previous episodes of upper GIT bleeding. Examination should also involve vital data examination in order to recognize patients with shock. Resuscitation and initial management is very important step to reduce mortality from upper GIT bleeding. We have to maintain airway, breathing, and circulation, recognition of patients with shock. And if there is hemodynamic instability, intravenous fluid resuscitation should be given. Blood transfusion should be given also in a restrictive blood transfusion strategy, which is adopted and recommended by most or almost all guidelines to maintain the hemoglobin level between 7 and 9 gram per liter. Using a validated risk stratification tool is very important to identify the patients, high-risk patients from low-risk patients, and to aid clinical decision-making. And it helps to determine the disposition of the patient, whether the patient is going to be discharged and perform endoscopy on outpatient basis. The patient should be admitted, and if he's going to be admitted, he's going to be in the ICU or in the ward. The most commonly used and cited stratification tools are Glasgow Platchford score, Ruckel score, the pre-endoscopy Ruckel score, AIMS 65 score, and the ABC score. These four scores are externally validated, but also there are many scores in the literature. Some of them are using the endoscopic parameter in their scores. However, a recent comparative study between the four scores reported that all scores exhibited poor discriminative ability for the composite endpoint, which is the mortality and hospital-based intervention like blood transfusion, endoscopic, radiological, and surgical intervention, with none of these scores achieving an area under the curve of more than 0.65. But the latest guidelines from ECG and the European Society of Gastrointestinal Endoscopy recommended and suggesting using of a Glasgow Platchford score to identify low-risk patients, not high-risk patients. Add those patients with a score less than or equal 1 could be safely discharged and perform upper endoscopy on outpatient basis. And the rationale of this is that the sensitivity of identifying low-risk patients at this score reaches more than 98.5%. Regarding pre-endoscopic management, the intravenous erythromycin before 30 to 120 minutes before upper GI endoscopy is recommended by most of the international guidelines, and it improves visualization and reduces the need for second look endoscopy. But unfortunately, we don't have IV erythromycin in Egypt. Nasogastric tube is not recommended routinely. Endotracheal intubation is not recommended routinely also, except in patients with previous GIT bleeding bleeding and fear. There is a fear of aspiration. Patients with deteriorated liver, conscious level, and agitated patients. Pre-endoscopy, giving PPI before endoscopy is a controversial issue. British Society of Gastroenterology recommended against using PPI before endoscopy, while ECG and ESGE didn't recommend for or against using PPI. AGA recommended for using PPI as it may reduce the need for endoscopic intervention. However, if you give pre-endoscopy PPI, this will not delay or abort endoscopic examination. In suspecting cirrhotic patients, you have to give vasoactive drugs like octreotide and terlipressin and antibiotic prophylaxis. Both of them will reduce mortality and reduce the need for and reduce the rate of rebleeding. Patients taking blood thinners like anticoagulation, antiplatelets, and if they develop upper GIT bleeding, we have to withhold and stop anticoagulation after consultation and with other specialties, cardiological, hematological, neurological. Endoscopic hemostasis could be considered safe and effective in patients who have INR less than or equal to 2.5. Higher INR values should not delay endoscopy. In patients with an anticoagulation with life-threatening blood and is taking vitamin K antagonist, consider prothrombin complex concentrate. And if he's taking direct oral anticoagulation, consider prothrombin complex concentrate or targeted specific reversal agents. While if the patient is on anticoagulation without life-threatening blood, only withholding of anticoagulation is enough. Don't give platelet transfusion except in patients with platelet less than 50,000. And if the patient is taking antiplatelets like aspirin for secondary cardiovascular prevention, you should not withhold aspirin in those patients. And if you are going to withhold it, if you are going to stop it, you have to start on the day hemostasis is endoscopically confirmed. And if the patient is taking clopidogrel, those patients clopidogrel should be stopped and restarted within the 5 days following its interruption. And if the patient is taking dual antiplatelets, aspirin should not be stopped, while clopidogrel could be stopped and should be restarted within the 5 days following its interruption. Timing of endoscopy following hemodynamic resuscitation, it's recommended early endoscopy within 6 to 24 hours after resuscitation. If the organic endoscopic intervention, if the bleeding is due to liver cirrhosis, endoscopic varicella ligation for esophageal varices, argon-plasma coagulation for portal hypertensive gastropathy, and gave injections chemotherapy for van der varices, and all of these failed tips for uncontrolled variceal hemorrhage and US coiling. For non-varicose upper GIT bleeding, there are many interventional tools like hemoclips, band in the loop, heat probe, ABC, injection of epinephrine, sclerosing agents, hemospray, in the clot, Purostat, vascoclip, and all of these endoscopic intervention failed. Of course, we have to go for interventional radiology or surgery. Force classification should be used to differentiate between high and low risk stigmata, high risk stigmata. Grade 1A, 1B, 2A, 2B, all of these lesions are high risk for rebleeding. So all of these patients should have endoscopic therapy. Patients with adherent blood clot, there is a debate to remove the clot or to leave the clot, but most of the guidelines recommend to remove the clot and to see whether it's a bleeding vessel or oozing or bleeding vessel or vessel, and to deal with this accordingly. But so be patients with forced 2C and forced 3, both of them are low risk patients, and those patients could be given PPIs and discharge. Regarding post-endoscopy management, patients with peptic ulcers should who received endotherapy should continue intravenous PPIs for 72 hours, and those who with variceal bleeding, post-active drugs should be continued for 72 hours. And if the H. pylori is present, H. pylori should be treated. Second look endoscopy is recommended in patients with if the first endoscopy was suboptimal because of difficult access, poor visualization, technical difficulties, or in patients in whom rebleeding is likely to be life-threatening. And if there is no source of bleeding is detected, CT angiography should be performed before radiological intervention. And if there are two attempts of endoscopic control of the bleeding are unsuccessful, avoid further attempts because of increased bleeding and mortality rates, and pursue surgical intervention. So the indications for surgery in patients with non-variceal upper GIT bleeding, severe life-threatening hemorrhage not responsive to resuscitative efforts, failure of medical therapy, coexisting reason for surgery like perforation, obstruction, or malignancy, prolonged bleeding with loss of 50% or more of the patient's blood volume, second hospitalization for peptic ulcer hemorrhage. And these are the guidelines and the references of my talk. And thank you very much.